I'm an osteopath. I graduated from BCom, Masters in Osteopathy. I assume that I recognise quite a few people here. There's quite a few osteopaths here, I'm assuming. Any other professions? Physiotherapists? Yep. Chiropractors? Yep. Okay. Massage therapists? Sports massage therapists? Yep. Acupuncturists? So we're all broadly in the same field. Anyone I've missed out that I haven't? No? We're all covered, right? So we're all broadly in the same field. So just to give you a bit of background on myself, I work at a multidisciplinary clinic called Cedar Hall Clinics. We've got two sites. One's in Thurrock in Stanford-le-Hope and the other one's in Benfleet. We've got osteopaths, physiotherapists, acupuncturists and chiropodists as well. And we all work as a team nicely, refer between each other, and we find it's a really nice way to work. So I'm not here to tell you that osteopathy is better than any other profession and the way I do things is better than any other profession, because to be honest, I don't believe that. The profession's only as good as the therapist. What I wanted to talk about today, they asked me to come and do a little chat about pain. So what I wanted to talk about today was sort of how we approach managing patients with persistent pain, because you apparently can't call it chronic pain anymore. It's got terrible connotations, very negative connotations. So we're now sort of describing this as persistent pain. And what we do to manage this. Now, a lot of the things I'll talk about are really relevant for most patients we see. And these are just my views, my approaches. I want this to be more of an open discussion, so please raise your hands. You know, if you disagree with something I put down, that's fine. I am not always right. I'm not that arrogant to think I am. So I'd like this to be quite an interactive chat. We sort of, you know, I'd like other people's points of views, thought processes, how you guys deal with it, and then I can sort of say how I deal with it. And it's just beneficial, I think, for all of us to go through these sort of things, because I know not everyone's as lucky as me to work in like a large multidisciplinary clinic. A lot of you tend to end up working on your own. It's isolating, and it's nice to be able to sort of come and chat amongst your peers and colleagues and sort of get fresh views and fresh ideas, or just confirm that what you've always been doing is right and you carry on what you're doing, if that makes sense. So first contact. So I think one of the big things with patients, especially patients who are suffering with chronic pain, is how we deal with them when we first meet them. Because especially ones with, persistent pain, I'm only using chronic pain, especially ones with persistent pain, is a good chance that you may not be the first practitioner they have come to see. They may have gone through like loads of other people, and you're like their last hope, because Janet, who you sorted her back or neck pain out like in 3 sessions, has told them that you're absolutely brilliant. They've got to go see you, and there's a huge amount of pressure on you. So I always find it's a really nice thing to do is to sort of find out the background of treatment that they've had already. Who have they been to see already? Have they been to see the GP? Have they been to see any other manual therapists? Have they been to see any other sort of therapist? Because it gives you an idea of what sort of treatment they've had previously. Because there's no point you going and doing exactly the same thing as they've had before if that hasn't worked. You know, Einstein said doing the same thing over and over again and expecting a different outcome is one of the major signs of insanity. And we don't really want to be viewed as insane, do we? So I think it's always good to establish what sort of treatments they've had previously, you know, where have they come from, what worked, what didn't work, and then gives you an idea of where to work from there. Because it may be that they've said, oh, I've done this, 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 and this, and you think, well, there's nothing really else I can do. And then we have to think about, right, who do we need to refer this person on to next? Where do we need to send them next? Because we don't want to waste anybody's time. We don't want to waste anybody's money. You know, we are in a really fortunate position to these people come into us wanting us to help them. And I think it's really important that we give them all of our duty and care, and we don't sort of go, well, we give it a go, you know, I could maybe try, and you just do the same thing over and over again, and they're not getting any better. So it's really, really important, I think, to make sure that we know what they've had done previously, and then we can decide what sort of treatment we should give or provide moving forwards. I always explain myself, and what I mean by that is I explain how I work as an osteopath, because as I'm sure you all know, osteopath covers a wide variety of styles of practicing. There's some people, like I'm very sort of biomechanical in my approach, I'm very hands-on in my approach. I use sort of quite strong I use manipulations, I use soft tissue release, but I also do a lot of rehab. I love functional rehab exercise. I really sort of push that the hands-on is important, but the bit that the patient does is just as important, because otherwise they're going to come back in every now and then, and I'm going to rub them better, and it'll be all right for a little while, and then it'll probably get worse again. So I like to explain my approach, because the patient might have a completely different connotation of what you're about. They might have a completely different expectation from your treatment. So if they're coming in expecting one thing and you do another, then they're not going to feel like they're going to be, hang on, this isn't what I signed up for. And they have a choice whether to be treated by you at the end of the day. Yes, they've come through your door, and yes, they're here in the consultation, but they still have a choice whether they want to be treated by you at the end of the day, and they need to have all the information up front to make that decision. To give you an example of this, and it's not related to an osteopath, physio, or anything like that. A friend of mine decided he was going to go and have a vasectomy. He's had 3 children now, the last one twins, and he thought, that's enough. I'm not going through this anymore. I'm going to go and have a vasectomy. And he'd researched it on the internet, and he decided that he wanted this specific approach of doing it, which is very non-invasive. They don't put you out, very like keyhole surgery style of doing it. And he went to the private hospital and had a consultation with the consultant that does the vasectomies, and they had the whole chat. And it wasn't until the very end of the talk that that the guy said, "Oh no, I don't do it like that. I do it this way. So if you want to do it like I do it, like more of the old school way." And my pal was like, "Well, I don't want it like that." He goes, "Well, it's no good. Like I'm not the guy for you." He still invoiced him 250 quid for that consultation, even though it wasn't what he wanted. So this is what I mean. It's really important to be upfront and to get people to understand what you do, why you do it, and how you work, because they may have other ideas of what they want from the treatment. Manage expectations. So persistent pain, long-term pain, we need to manage expectations. It is unlikely that we are going to get them fixed in a flash, isn't it? I would have thought most of us, we always get those golden ones through the door that take 2 sessions and boom, they've got no pain anymore, and you just think, yes, that's brilliant. But with long-term persistent pain, there's normally some sort of dysfunction that's been going on there for a long time, something that causing this, and it's going to take time to get to the root of the problem. We've got tissues, muscles, and everything that have been joints that have been under strain for long periods of time. So we need to make sure that we manage expectations in the sort of amount of time our treatment's going to take, because we can't have them thinking we're going to get them better in 3 sessions when realistically it's going to take a lot more time, a lot more involvement from them, involvement from us to do that sort of thing. I'm very keen on finding the cause, not the symptom. And I think a lot of patients come to you and they may have been to see other medical professionals and they say, "Oh, I've been diagnosed with sciatica." Sciatica to me is a symptom, it's not a diagnosis. And this is my viewpoint on it, and you can agree and disagree with me. I'm fine with that, it's not a problem. Sciatica is irritation down the sciatic nerve pathway. But what is causing that sciatica? Is it a disc prolapse? Is it a herniation? Is it piriformis syndrome? And then why has that happened? Why has that been allowed to happen? Why has this person had a disc prolapse? Did they try and do a 250 kilo squat and then their back just went no? Then we know it's a mechanical, it's traumatic. But did this come on gradually? Is there long-term sort of dysfunction in their movement pattern, how they're moving? Are they weak in certain areas and they're overworking other areas? And has this been a chronic issue that's building up? And everything has a tolerance, and that tolerance at some point has to give, and that's what's given. And the patient will appreciate this. They want to, because if you can explain to them why this has happened, it gives them an understanding of what's been going, what they've been doing wrong maybe, or what's wrong in the in their lifestyle that's causing this, or whatever factor it is. And then it helps empower them to change these things, because if you can say to them, well, because of this has happened, but if we do this, it will help it and correct it, then they're more eager to take on those sort of things. They're more eager to make those changes, because a lot of time getting people to make these changes is half of the battle, I find anyway. So finding the root cause of the problem, I think in my eyes, just means that we can better inform our patient. It informs our idea of practice a little bit better, and just helps us sort of move along a little bit more. Referral. So we don't know everything. We can do orthopedic tests, as was stated before by the, and they give us a good idea, but they're not 100% foolproof. And sometimes things don't add up. And if you know, if there's something there you just think this isn't quite right, something doesn't feel right to me, then referral for further imaging I find is really useful. Now, I don't think everyone should be MRI'd or X-rayed as soon as they come through the door. I don't feel it's necessarily, but if you've done your tests and something's not adding up, or you've been doing treatment for a little while and the improvements haven't happened in the stages that you would expect given the diagnosis that you've made, then I think referral for further imaging is a useful tool. Now, there are times where, like we said, we could MRI all of us in here and 30% of us would probably have a non-symptomatic disc bulge, and that's fine. But if there is pain, there is a problem, and it gives us and imaging that helps us understand that and why it's happened. Again, that's a really useful tool for the patient. You know, getting them to understand their pain and why it's there is hugely, hugely beneficial. And then even I've had it before where I thought this isn't right. I had it actually recently, last month, a patient with knee problem. This isn't right. You know, it felt like there might be some sort of meniscus damage in there. We'd done the rehab, was getting a bit better, and then things were having then we're getting little setbacks. The patient said to me, she goes, I'd like to have some imaging done on it. I said, that's fine, I can arrange that for you, and we referred her for an MRI. Came back, and the MRI was fine. Like, no sign of meniscus damage, no sign of meniscus tear, a little bit of inflammation through some of the tendons. But as soon as she knew that, as soon as she knew there wasn't any meniscus, huge weight lifted off her. Huge, and a sort of sigh of relief, and she's like, fine. Since then, her pain has reduced dramatically. So there's always that sort of worry in the back of their head that there is something more serious. And as I said, I'm not saying we need to image every patient, but sometimes no negative result on your MRI or X-ray can be just as useful as like a diagnostic result. Okay. Any thoughts on any of that? Any questions? No? Okay. Explain your diagnosis. So this is what I'm moving on for. Explaining to the patient your diagnosis, like getting them to understand why you've made that diagnosis, what things have brought you to those thoughts. Because as soon as they understand why it's there and the reason for everything, they'll, again, it's that huge weight off their shoulders. And unfortunately, we're in a really fortunate position. We've spent a long time studying, learning. We have good understanding of the human body, but most people don't. And I think it's a shame. I think it needs to be taught more in schools. I really, really think that more education at an early age on our body and how we use it and how we should maintain it should be done. But a lot of people don't understand. And to give them that little bit of knowledge and give them those tools to understand, you know, why they've got a problem is hugely, and get them to understand their body and understand that, like, some muscles go from all the way, you know, your trapezius goes from the base of your neck to the middle of your back, and people don't know that. And then that's why you've got back pain and neck pain, you know, it's referring up the whole full length of the muscle. And as soon as you tell them things like that, it's that weight lifted off them and that understanding of themselves. I love, oh no, ignore that. I love pictures, props. I love bits to show people. We've all got those nice anatomy diagrams in our clinics, I imagine, that we've bought and hung up on the wall. Get the patient over to it. Point to them. You know, this is this is that. This goes to here. That's why that's sore, and it's referring over to there, and that's why you got that problem. People understand things very visually, I find, and if you can portray that to them visually, if you can understand what's going on in their body, and you can help them to understand what's going on in their body, again, it's really beneficial for them, because a lot of the time this stuff isn't explained to them by other healthcare practitioners, and it goes over the top, and they're told they've got this problem, and they don't really understand the connotations of that and what it means and why they've got it. So you know, let them draw a picture in their mind of what it is. Use these images, these little plastic skeletons and spines and knees we've got. People got we band around the word meniscus all the time, but no one knows what a meniscus is. And then when you explain to them the meniscus is the cartilage in their knee, oh right, okay, yeah, I've heard of cartilage. That's fine. So use these tools. It's really, really beneficial. Do people do that? Do you point out? Do you stand there going, this? Have a brief. It's good revision for us as well. It's nice to have a little anatomy revision. That's good. I find it really beneficial. So we are is everybody here in the sort of more private sector? Anyone NHS based or, you know? So we are in the private sector. We dictate our own diary slots, our times and everything. So we are fortunate that we do have time. I'm not talking about the magazine. One day I'll be on it. It'd be nice. It'd be me up there with Dwayne Johnson on the magazine. Never know, eh? But we have got the time to do this. We have got the time to give to patients. We're not like GPs. We're not restricted to 7-minute slots. So, like, you know, and patients appreciate that so much. Yes, they're paying for your time. Yes, and it's an investment for them. But they appreciate you taking their time to you. So if it means taking those extra couple of minutes with someone just to be a bit more thorough or just to get them understanding what's going on, like that is so rewarding for them. It's so great. So use your time. You know, we're in a great position for that. We've got that time, so make the most of it and really, really like help these people. And then moving on from that, be realistic with time frames going forwards. So this is what managing expectations. We're back to managing expectations. If someone has been in persistent pain for a long period of time, be realistic with how quickly you're going to get them out of that pain. You know, if there's been long-term postural problems, you know, from the past 20 years of sitting at a desk for 8 hours a day, not doing any exercise whatsoever, we've got to be realistic with how quickly we're going to get them back to sort of the norm or like more effective use of their body. You know, how quickly are we going to get them to build up muscle tone and strength again? How quickly are we getting them to improve their posture and break this learnt cycle that they've been stuck in for the past 20 years? I mean, I'm sure we've all seen it. Someone that does pretty much no activity whatsoever, and part of the battle is getting them back doing that. So, you know, you've got to explain to them that this isn't going to be a quick process sometimes, you know. It's going to be a bit of a journey, and you're happy to be there with them through that, and you will manage them through it. And it doesn't always need us to be there. Very rarely I find it needs us to be there every week of this journey, maybe at the beginning, but then we start empowering them, giving them the exercises to do. They start feeling a bit of progress, I tend to find that I work in a way that I have these sort of check-in points to get them to come back. They may need a little bit more treatment after that, and then we go build from there. And it's always nice to meet. That I put here, use activities as a measurement. So I like to set, you know, goals and markers. So if someone comes in and they're in so much pain they can't put their socks on, then in a couple of weeks later you say to them, how are they feeling? And they're like, well, I feel a little bit better. And they're like, right, can you put your socks on now? Like, oh yeah, I can put my socks on without any pain. Like, well, you couldn't do that 2 weeks ago. Pain is very quickly forgotten, or levels of pain are very quickly forgotten, I find. So if we can, and then if you give those little gentle reminders, all of a sudden they're like, oh yeah, I could put my socks on 2 weeks ago, you're right. You know, so you're noticeably better, because half of the battle is, you know, they are expecting like to go from VAS 10 to 0. I hate VAS scale. I don't think anyone really understands it. I don't think it works. Everyone comes in and tells you you're 10. They're 10, they're not. You know, you'd be comatose if you were in level 10 pain. I don't like it. So I find these sort of activity measurements much more useful. You know, can you climb the stairs paid free now? Can you get in and out of your car? Can you drive now? You may not have been able to, they may not have been able to drive the first time they see you. Can you walk further than to the kitchen and back again now than what you could do before? And if they say yes, it just prompts them. They go, oh yeah, you know, I can do that now. And these are great little milestones for them to understand, them to record, and they realise that they're getting better, and it helps them have more confidence in you, because you know you want them to feel like you're getting them better. You want them to feel like you're helping them, and by reminding them of these little markers, it improves these things. I always explain to them that healing isn't linear, so you never go, I'm better. It's sort of a wavy, bumpy road. We get good days, we get bad days. Eventually the good days outweigh the bad days. It takes a little bit of time. We need to, and if you explain that to patients and they understand that, they're much better, and they won't ring you up in a blind panic. They're like, I've been really bad today. I've been really bad. It's terrible. And what do I do? It's all gone wrong and all. And if you explain to them that it's going to take a little bit of time, and you're going to have days that are good, the days that are bad, they're much more accepting of this, and it's getting them to understand these things and move forward with them, and it just helps, I find. Everybody's different. We know this because we see lots of different people each day, and none of them are the same, and none of them do the same things, and none of them move in the same way. None of them have the same levels of activity. So everybody will heal at different rates. And age has a big factor in this, obviously, but still, you could have two people the same age, and one may respond to treatment much quicker than another. So manage expectations in that way as well. Explain to them, healing rate isn't static. We give these guidelines of 6 to 8 weeks or things like that, but it is just a guideline. We can't be specific. So, get people to understand that that there's no set rule of healing times and things like that. And as I said before, how long have they been in pain? I always sort of use it as a rough rule of thumb. If you've been in pain for a long time, it's going to take longer to heal, rather than a more acute injury that we may be able to recover slightly quicker. Treatment. I'm sure a lot of you here have been in practice a lot longer than I have, so I'm not going to teach you how to suck eggs and tell you how you should treat these people when it comes to your protocols in how you do your hands-on and how things like that. But I want to sort of touch on a few subjects and sort of my approach to things and how I do it. I'm not going to go into techniques and stuff like that. That's not what today's about. But hands-on, I'm a big believer in hands-on. I think most of us are in this sort of private sector. I don't believe in just giving people a sheet of paper, getting them to go and do the exercises, because again, they feel like they haven't had any benefit, they haven't had any treatment. And there's that expectation of treatment when you're paying to come and see one. So I do believe hands-on is really, really good. The level of hands-on is dictated about how you work and your patient as well. How I treat my 85-year-old patient is not the same as how I would treat a 20-year-old power lifter. It's very different, and the way I treat those two people is very different. So your patient should dictate your hands-on treatment to a certain extent. Refer. Now, the reason I've put this is because sometimes we get people that are just in so much pain we can't touch them. Have you ever had that? Nothing you do helps. You try, do this way and then that, and you want them. They need to be starting to do a bit more activity. They need to start to do a bit more exercise, but the pain is stopping them from doing that, and we need to break that pain cycle, that loop. This is where referring to people like orthopedics and stuff for things like injections and stuff like that, I find very beneficial, because the injection is not a cure, and I always explain it, it's not a cure to your problem, but what it will do is it will stop the pain, and it means that we can start progressing your physical therapy. We can use a little bit more hands-on technique. We can get you doing a bit more exercise than you have been doing and your body's allowed you to do, because you're not in that pain, and it breaks that pain cycle. Unfortunately, I think what happens a lot of time with injections, patients go and have an injection, they're like, oh, my shoulder doesn't hurt anymore, it's fine, I don't need, I'm cured, and then they don't come and see anyone like us. They don't have any physical therapy because it doesn't hurt. And then the injection wears off, and they're like, oh, I'm in pain again, and it hurts, and I don't know what to do. So I find that actually doing the physical therapy in line with injections and stuff, if the person is in so much pain that you can't get them to do the things you want, really, really beneficial. And that's why I put referral down in this category, but only when it's applicable. We don't need to be injecting everybody just to sort of kill their symptoms off so we can get them running up and down the road a bit quicker. Now, rehab. Big believer in rehab. I think osteopaths as a profession are moving more and more towards this. It's something that was neglected previously in our profession a little bit, and there's been a big movement towards it in the past few years. It's really, really useful. Why I find it useful is that, and the way I find it useful is that it can change the way patients are using their body, and it can stop the same problem recurring over and over again. And then also, if they've got, it might be that you've got an athlete, someone that competes at a high level, and they've had quite a serious injury, and we get them better, but then you've got to build their strength back up. If they go back straight into trying to do what they used to do, they're going to re-injure themselves, and they're going to be back in with you again with the same problem or worse problem. So having rehabilitation from that point of view, I think is key, because it allows us to progress our patients, get them back to where they want to be. You need to set set goals. You know, what do they want to be able to do? And again, this is different for each patient. You know, someone just might want to be able to get up off the sofa, go into the kitchen and lift the kettle to make a cup of tea. You know, that is their goal. You know, that will make their life easier, and that's fine. And we rehab in a way that is specific to that and to get them to do that. If we can then move forward from that and get them a little bit more, because we've built their confidence up, and that's a huge thing with people in persistent pain. If it knocks their confidence, if they've spent years in pain and worrying about doing things, you know, worrying about, oh, I don't want to go down those stairs because I might have another fall, you know, we've building their confidence back up and giving them the confidence to do things again really can improve their quality of life and means that you can sort of move forward with their treatment. So I do find that rehab is really, really important. So yeah, build their confidence, set achievable goals, be realistic with their limitations. Patient of mine came in, she'd had a knee problem and she'd been given a sheet of exercises. All of those exercises involved her lying down on the floor. This woman is 86. She finds getting up and down off the floor a little bit difficult, even without a knee problem. So let's, rather than just printing off a sheet and saying, which I'm sure none of us here do, like, you know, these are the exercises that are good for knee rehabilitation. Let's look at our patients and let's see, right, you know, can they lie down on the floor? Would they be better off sitting? Can we give them exercises sitting? Is that more comfortable for them? Yes, it probably is. Let's do that then. You know, exercises can always be altered and changed and adapted to give the best care for that person. And this brings me on to I was always taught, do not technique your patient. So just because a certain method of treatment is known to treat back pain really well doesn't mean it's suitable for every patient, you know. And it's same for rehab. Do not just because that exercise is very good for knee pain doesn't mean it's applicable to every patient. We need to look at what they're doing with their day-to-day life, their capabilities, you know, what they have access to as well. You know, you might have people that do have a gym membership, so we can get them back in the gym and we can say to them, right, you can use that bit of equipment, you can do that on it, that on it, that on it, that on it. But then you probably have someone that doesn't have a gym membership. So what we're going to do, we don't want to tell them to go and start spending £30, £50 a month on a gym membership that they don't really want because they don't really like the gym. There's a huge amount of rehab that you can do with just using the person. I'm a big fan of calisthenics. I do all my training as body weight resistant. I don't really touch a weight anymore. I don't have a gym membership. I've got a pull-up bar and in my garage, and that is pretty much all I do. And I'm happy, and I think it's more of a functional movement. And there's loads we can do with patients, just getting them to start using the surfaces around them, floors, walls, and just getting them moving their body and we can start off with a little bit of assistance, and then we can build it up to still there's like doing it all on their own. So make sure you understand what they have at their disposal, and then we can make the rehab more sort of applicable to them. There's no point me telling someone that they should go and do Romanian deadlifts if they haven't got a gym membership. Right, compliance. Compliance is a big one with rehab. I'm sure we've all had it. They come back in the next week. You any better? How do you feel? Or still in a lot of pain? Did you do your exercises? I asked you. Well, sort of, maybe, a couple of times, which means no. We all know it means no. So how do we get them to comply? It's a difficult one. You're not always going to win that battle, I don't think. I tend to use money. I don't bribe them. I tend to explain to them, if you do your exercises, you'll have to come and see me less, which will save you money. And then I find that works. It's a terrible business model for myself. I don't earn as much, but I sleep at night, and that's what's important to me. So yeah, compliance is a big one. You have to sort of, again, it's this giving them the information, helping them understand why you're giving them these exercises. You're not just going, oh, you should do these exercises. Explaining to them why these exercises or this rehabilitation program that you've given them is important. You know, why there'll be benefits, or that it's gonna cause, and the pain's just gonna come back. On the refer point of treatment, increasingly I'm seeing, and maybe it's just I'm paying more attention these days, I'm seeing a lot of problems that are coming up from the feet. Anyone else see a lot of problems that are caused by the feet? Yes. overpronation, dropped medial arch, all these sort of things that are causing a complete change in gait, altered biomechanics, strains to the knees, strains to the hips and stuff like that, all these sort of things. And they come in with knee pain, and everyone's quite shocked when I say, okay, your foot's causing your knee pain. But once you explain it to them and they understand, and a lot of the time I find I'm referring to osteopathist. She does really nice tailor-made orthotics. I mean, I tell people to get the ones off the internet as well, because sometimes it's quicker, easier, and it's a good, you know, you can buy them for £7. It's relatively inexpensive, and it's a good way of them understanding whether, you know, and then they put them in and they go, oh, it does feel better, it does feel a bit easier, and then they're happy to get something that's a little bit more bespoke, a little bit more specific to them. And the advantages I find of that is we have lots of different footwear, and having something that can manoeuvre in and out of all of those footwear. You don't always want a great big chunky squidgy insole in a set of nice delicate shoes. I mean, so yeah, I find that really useful as well. And then you work together and alongside each other to sort of carry on managing the problem and making sure that everything's all right. Any questions on that point? Anyone disagree with anything? I don't mind. I'm not easily offended. Anyone do anything different? Anything I've missed out? Nope. Okay. End goal. I think it's always nice to have an end goal with a patient, and then we talked about this about marking sort of milestones and things like that. You know, where do they want to be? Your end goal for your athletes is very different for your end goal for your retired patients who, like Bob, just wants to get back on the golf course 3 times a week, or your weekend warriors like myself who want to go and chuck ourselves down the side of a mountain on a mountain bike. You know, what is that goal? Where do they need to be? And then you can explain to them like how you're going to achieve that. And be realistic what you can achieve. Unfortunately, sometimes we can't always get them 100%. I want to, we all do. It's horrible when we can't, but sometimes some conditions, some problems, you know, we have to be realistic with where they're going to be and what they're going to be able to do at the end of the day. And it's difficult for us as practitioners to be the ones that deliver that news. I find it is anyway. I never like to tell someone that they're not necessarily going to be able to go back to doing what they want. I love it when they prove me wrong. I really, really do. But we have to be honest. You know, don't lie to patients or don't sugarcoat stuff. Don't sort of I don't like to tell them what they want to hear if it's not the truth. You know, they've got to, you know, because otherwise you're going to come to the end of your treatment and they're going to go, well, you know, you said this was going to be fixed and it's not. You know, and then they're going to lose faith in you, and that hurts your profession, like your reputation. You know, we all work on reputation. I assume we all work on referrals. Are a huge part of my business. I want people to come back and see me and refer to people, other friends and family to come and see me because I've helped them and they believe that I've given them the best treatment I can. So I think it's really important to, you know, understand end goals, manage expectations, and get them to understand all of that. And it's, yeah, what does the patient want, and tying it all in with those sort of things. Has anybody had any experiences with any of this, difficulty with these sort of problems, anything like that? Nope. Okay, fine. That's it.